Alright, so here we come again. Still trying to test the microphone and the sound input. Don't know if you can get me, but if you can hear me, please indicate in the comment section that you can hear me. So our lecture today, we are going to discuss drug management of peptic ulcer disease. Now, we have specific types of objectives of this lecture. So at the end of this class, students should be able to describe the physiology of acid secretion and how it is implicated in peptic ulcer disease. They should be able to say the general therapeutic goals for the management of peptic ulcer disease. Students should also be able to classify and explain mechanisms of action of drugs used in the management of peptic ulcer disease, recognize common adverse effect patterns and drug interactions, outline H. pylori eradication regimens, and as well as should be able to discuss the management of NSAID-induced ulcers. Now we are going to start this class with an introduction. Now, by way of introduction, an ulcer is a break in continuity of mucous membrane or membrane lining. In the case of peptic ulcer, as the name implies, it is a break in the stomach or duodenal mucosa. Now, there are two entities that make up peptic ulcer disease. One is gastric ulcer and duodenal ulcer. They have similar type of clinical presentation. However, they have some dissimilarities in terms of location, the pattern of presentation. Let's quickly delve into the different patterns of presentation and the other types of differences that they can present with. So stomach ulcer, as the name implies, it is located in the stomach and presents usually with food, because whenever we have meals, as the food gets into the stomach, acid production increases. So with increased acid production, we expect that the acid enters the ulcer wound and send pain signal to the brain, and we start having stuff like dyspepsia, heartburn, and stuff. Then the duodenal ulcer, usually pain comes with empty stomach. Usually at night, patient can wake up in the middle of the night with excruciating epigastric pain. This is because at night we tend to secrete more histamine, and we know what histamine does to acid output. Now, histamine secreted will bind to H2 receptors present on parietal cells and increase intracellular cyclic AMP. From intracellular cyclic AMP, they can stimulate protein kinases, which will eventually phosphorylate the proton pump and increase acid production. Then the duodenal ulcer, usually they are relieved by meal. This is because when we eat, the food in the stomach actually buffers the acid, and as well, to hold the food in the stomach, the pylorus contracts for quite a period of time before it will allow the food to transit to the next part of the GIT. So having known these similarities and dissimilarities, let's discuss how the parietal cells in the stomach secrete acid. Now, as you can see, this is, if we zoomed in on one parietal cell, this is what we get. We have two faces to this cell. We have the basolateral and the apical membrane, and we have several transporters that would help in the secretion of acid. Now, if you watch closely on the basolateral aspect, we have a transporter which is an antipod. It transports bicarbonate, or it exchanges bicarbonate for potassium. All right, so let's go and see how this played out. Hope it's better. So stop the stream and play to